Okay, this is going to be the last part of schizophrenia, and today I should also be talking about substance abuse or drug addiction, at least for a little while. And then Wednesday we will discuss over the internet some research articles on various psychological disorders. This is all repetition to put us back into the context of where we were and these hypotheses about schizophrenia, and specifically about which neurotransmitters are dysregulated, or which neurotransmitters are really the cause of schizophrenia. As both of these are dysregulated, the question is which is the cause, because they do have this interactive kind of relationship, this kind of balance with each other. But the dopamine hypothesis of schizophrenia is that schizophrenia results from excess dopamine, and so they are releasing dopamine faster than average or normal people. And so neurons are synthesizing more to replace those molecules that they're not reabsorbing. And so we end up with this excess of dopamine. And the other hypothesis is the glutamate hypothesis of schizophrenia. Schizophrenia may also result from deficient activity of glutamate synapses, especially in the prefrontal cortex, really especially in the hippocampus and the prefrontal cortex. And as I said before, so dopamine is what we see as being raised in those drugs that can cause some of the positive symptoms of schizophrenia. So methamphetamine, cocaine, if we take enough of them or take them long enough, we can end up with paranoia, delusions, and hallucinations. But it does not, those do not influence those negative symptoms so much. And they don't, this isn't a long-term problem. This is something that once we withdraw from the drugs, we clean up the system and we get back to normal, if this was just a drug-induced schizophrenia. And the glutamate hypothesis is really suggesting that it's a lower or deficient activity of glutamate, and this appears to explain a lot of things, including the fact that we don't see the effects until puberty, which I think I explained in the last slide. We also saw other reasons why some of the negative symptoms don't occur until puberty, but the glutamate hypothesis is clearly very important as well. And one of the reasons we know that it's a really important hypothesis is because of the difference between PCP, or phencyclidine, and those other drugs that cause what we call the drug-induced schizophrenia of amphetamines and cocaine and those kinds of dopamine agonists, where PCP, if somebody who is schizophrenic and has recovered and is in a state of doing better, if they do PCP, we see these severe effects and a long-lasting relapse into schizophrenia. Whereas with amphetamines, cocaine, and so forth, we can see the drug-induced schizophrenia, but we don't see this long-lasting relapse where someone can become schizophrenic again if we see a schizophrenic person who's doing those drugs. So, so PCP is inhibiting the NMDA glutamate receptors. And remember, when we talked about learning and memory, that the NMDA glutamate receptors are allowing in calcium, and so they're allowing for cellular change. And it's a really dangerous and not good thing to be inhibiting those glutamate receptors. We see that to some extent also with alcohol, but not to the same extent as we see the effects of PCP. We also, if we look at what happens to people when they take PCP, at lower doses, we see that kind of intoxication and slurred speech, where they might look like they might have just drunk some alcohol. At higher doses, we see both positive and negative symptoms of schizophrenia. They've also done studies on mice where they have given them PCP or ketamine, which behaves somewhat similarly to pre-adolescent mice and then to adult mice. And PCP and ketamine have little effect on pre-adolescents, and they have their effect on the adult mice. So again, it looks like even if we have some dysregulation of glutamate as we're aging, that we don't see the effects. We don't see what looks like schizophrenia until after puberty hits. So administering glutamate is risky. It is a widely distributed excitatory neurotransmitter. And if you're catching on to this, the NMDA receptor, we've talked about this in learning and memory, it causes cellular change. This is not something we want to do widely throughout different areas of the brain. Drugs that stimulate particular kinds of metabotropic glutamate receptors have shown promise in treating schizophrenia. I have my some citations there. My understanding, I have not read those, but my understanding is this is based on an animal model at this point. Another promising avenue is that the NMDA receptor has a primary site that's activated by glutamate and a secondary site activated by glycine. And I think we did this early on in the semester when we talked about neurotransmitters, and we talked about, I'm not sure if I do this every semester, so I might not have, but I often show the GABA receptor and the glutamate receptor, and they both have several binding sites where different chemicals can either facilitate or antagonize the influence of the neurotransmitters. And in this case, if you remember, glycine is an inhibitory neurotransmitter that mostly we see in the spinal cord, that is there so that we don't overextend muscles or overcontract muscles. So we have that inhibition. But glycine also fits into a secondary site on these glutamate receptors, and it facilitates the activation or the effects of glutamate on these receptors. And so some of this is repeat again, but glycine does not activate the receptor. It can increase activity at the NMDA synapses it can do this without overstimulating glutamate throughout the brain. And so glycine agonists are not effective as an antipsychotic drug by themselves, but they can increase the effectiveness of other antipsychotic drugs. So if we talk about treatments for schizophrenia, which I know we've already sort of started talking about because they help us to get at those neurotransmitters, but some of the newer drugs are a bit cleaner in the way that they're acting. And again, I started introducing this, and I think Callett does this too, where he starts introducing this concept, but I'm going to go into it a little bit more deeply as we're talking about these brain regions, these neural pathways. So we have several dopamine pathways that have different functions, where actually this should feel like comfortable territory, I hope, for a lot of people. So one is the mesostriatal system. We talked about that a great deal when we talked about movement. That is that includes the projections to the basal ganglia, and the mesostriatal, so the striatum, the midbrain to the striatum is the system that is influencing our movement. We also have the dopaminergic reward pathway, so this mesolimbic system from that midbrain tectum, from the ventral tegmental area up into the limbic system, up into the nucleus accumbens, which now I think I've mentioned a couple times. And when we start talking about substance abuse, I'm going to continue to talk about that mesolimbic system. And it's actually a mesolimbocortical system, if you love that word. So it's going from the midbrain to the limbic system up and to the cortex as well, as we're going through the limbic system to the prefrontal cortex. And that is the system that we really want to influence when we're blocking dopamine in people with schizophrenia. And we do not want to influence that mesostriatal system. We don't want to influence the basal ganglia. And when we are doing that, that is when we sometimes see that side effect of tardive dyskinesia, which I was explaining on the previous bunch of slides. So tremors, other involuntary movements, sometimes muscles getting stuck in a particular position. So some of the newer drugs, second-generation antipsychotics, they are less likely to cause that tardive dyskinesia. They are often working on dopamine and serotonin sometimes, but risperidol, Zyprexa, we don't see so much tardive dyskinesia. They do have heart-related side effects. So if we come to the sort of end of what we can say about schizophrenia, as again, I've had lots of slides with lots of information and sometimes lots of words with listings, and it is neither a one gene nor a one neurotransmitter disorder. There is nothing clean or easy when talking about schizophrenia. And if we get to talk about autism, which I don't think we're really going to talk about it much, so I'm going to do a little bit here, we see something really similar in how it is many, many different genes. And so the etiology, where it's coming from, is going to be so different for different people who show the disorder that really it's a heterogeneous disorder. That it's different in different people. And usually, and I think I said this at the beginning for schizophrenia, but usually the way they talk about autism is if you've met one child with autism, you've met one child with autism. And that's really true for these heterogeneous disorders. They're not easy to talk about. We can't look at a gene or a particular brain region or a particular neurotransmitter and say that's the explanation, as it is just very complex. There are environmental issues with schizophrenia, and they're so either intermediate risk or low risk that it's difficult to figure out what's even really a risk factor.